tried sharing my screen, I was doing like an online camp with a bunch of kids and they had to coach me through it. So hopefully they taught me well.
You got this.
Okay, so can everyone see this? Good?
Yep, good to go.
Thank you, Galdu, for that introduction. My name is Lauren, and today I'm going to be talking to you all about integrating behavioral markers of disease into personalized healthcare and neurology. So as future neurologists or just future clinicians, I just want us to incorporate patients' mental health into neurological care. And as we'll soon find out, I think that's going to be interesting to keep in mind for certain patient populations as well. So the article that we're going to discuss, which maybe you all had a chance to glance at, if not, don't worry about it, because I'll cover it pretty thoroughly. But it was Racial and Ethnic Disparities in Serious Psychological Distress among those with Alzheimer's disease and related dementias. And so this research was carried out at the University of Maryland, College Park. So, and there we go. So a brief outline. First, we will just introduce Alzheimer's disease and its relationship to depression. We're specifically going to talk about the directionality of those two because it hasn't been fully understood yet. And next we'll get into diagnostics, which leads us into the hypothesis of the paper. Follow up with methods and results, and then finally have a discussion on how behavioral markers can give us a better picture of our neurological patients. So introduction, Alzheimer's disease, it's a progressive neurodegenerative disease that can have a really profound impact on patients' quality of life, particularly in later stages. It's sporadic in most cases and has an increased incidence with age. Some of the symptoms include cognitive decline, impairment of daily function, and behavioral manifestations. So when I first learned about Alzheimer's disease, the behavioral manifestations were more so things that you saw in late stages of disease, and they were things like delusions and paranoia. But what we'll be talking about today are some behavioral manifestations seen early on in the disease process. So specifically, we're going to be talking about depression. So the temporal relationship between depression and Alzheimer's disease is still not completely understood. There are some studies that show that early depression might be a risk factor for later development of Alzheimer's disease. There are other studies that show that not early cases of depression, but rather later cases of depression, like after the age of 50, are associated with an increased risk of Alzheimer's. And in those cases, it might actually be an early manifestation of the disease process itself. And those symptoms of depression are, more so due to the subcortical atrophy of white matter. And so another thing that we can keep in mind is because Alzheimer's disease can be so devastating for the patients to go through, as they see their decline in function and difference in the way that they're living their daily lives, it's understandable that they would experience symptoms of depression from that. So if we have an even patient and we're thinking about how their psychological health has impacted their, we'll say, recent onset Alzheimer's disease and vice versa, we can think about how depression might have been a risk factor for them developing Alzheimer's disease. It might be an effect of the disease process itself, or it might be a comorbidity just from living with a debilitating illness. So I think it's important for us to talk about the diagnostics of Alzheimer's disease because the overall umbrella of some of these conversations that we've been having is we're wondering which tools are most useful for certain populations and which tools are not as useful. So I think what we're, all probably pretty familiar with are, the neuropsychological testing, like cognitive function tests. There are also imaging techniques, standard imaging to rule out other causes of dementia. We've also talked about newer imaging techniques like PET scans to look for levels of amyloid beta in patients. And, what we're probably all most familiar with at this stage in our education are, the pathological findings of the amyloid beta plaques and neurofibrillary tangles that are seen at autopsy. So when we talk about patient-reported tools. I think at best it's a way to possibly catch a disease process early on. For instance, there's some studies that show that a patient's subjective loss of memory might precede, dementia. And so along these lines and, more along behavioral measures of health, we're going to be talking about subjective scores for serious psychological distress. So the hypothesis of the paper, does self-reported serious psychological distress contribute to the burden of Alzheimer's disease and related dementias in minority populations compared with presence of an anxiety or depression diagnosis? Okay, so for the methods, the researchers did a cross-sectional study and they went through 8 years worth of data. So there are quite a few participants in this study, and a lot of information was gathered, as we'll look through in the next few slides. So first of all of the participants were aged 65 and older, really looking at how increased age is associated with an increased risk of Alzheimer's disease altogether. So looking at the older patient population. And as for the distribution of participants, 65% of them were white, 19% were African-American, non-Hispanic, and then 15% were Hispanic. So the patients listed their medical conditions, and the ones that are most noteworthy that we're going to talk about are obviously the presence of Alzheimer's disease and related dementias, or ADRD, as I'll say, also the presence of anxiety and presence of depression, and also quite a few other variables. So some information on socioeconomic factors, and the key independent variable that we're going to be looking at is the serious psychological distress score. So what is serious psychological distress? So it was measured with this K6 screening question, and I'm not sure if you guys are familiar with this, but it's actually been used in like national studies before as a screening tool. So it specifically uses a screening tool to predict serious mental illness, and people who have high scores on this are recommended to seek mental health help. So during the past 30 days, basically patients were asked, if they had feelings of anxiety, things like, do you feel nervous? Do you feel restless or fidgety? And then quite a few of these questions were centered around depression as well. Do you feel worthless, hopeless, so down that nothing could cheer you up, or that everything was an effort? So for each of these questions, a score of 5 meant that the patient felt that way all the time. And sorry, I keep saying patient, I realize, but I really mean participant in this study. I think as a student doctor, I'm used to saying patient all the time. So participants with a score of 13 or higher across like all of these 6 questions were placed into the SPD category for this paper. Something else to keep in mind, I'm kind of wondering about, why the researchers came up with this threshold in particular, and what someone with a score of 13 versus someone with a score of 20 looks like in terms of the risk factors, but we can talk about that later. So first, if we just look at the right side of this graph compared to the left, we're looking at patients in all 3 populations who have presence of Alzheimer's disease and related dementias. And what we can see right off the bat is that they have higher levels of serious psychological distress, depression and anxiety compared to the participants that do not have Alzheimer's disease related dementia. So already we can say, did this study tell us about whether SPD is necessarily a risk factor or a comorbidity with Alzheimer's disease? No, it does not answer that question. But we can sort of use it as a behavioral marker. And in the discussion question, I'll talk about ways where we might be able to use this marker to try to figure out the timing relationship between these two. So for starters, like I said, significantly higher rates of SPD, depression, anxiety in these participants. The next thing I want us to look at, though, is that I had mentioned that K6 screening tool was used to look for participants who might be in need of mental health services. And if we look at the white participants in this study, we see that the serious psychological distress score is pretty similar to the rates of depression and anxiety diagnoses in those participants. And that's kind of what we would expect, right? However, if we look at the African American and Hispanic populations, not only do they have higher serious psychological distress scores compared to the white population, there's this huge divide between the level of serious psychological distress and whether or not they have a depression or anxiety diagnosis. So, this to me points towards the fact that if we're trying to use serious psychological distress as a possible behavioral marker for neurological disease, the SPD score seems to be much more reliable and a better diagnostic indicator than the presence of anxiety or depression in these specific populations. And that's everything I said in typed form. So going further into the data analysis, and this table's a lot, but basically covariate analyses were run to control for all of the other variables and information that were collected. So for model 1A, it happened to be everything highlighted in yellow. So socioeconomic and demographic, even geographic factors. And in model 1B, everything highlighted in blue, controlling for other health problems that the patients reported. Again, I kept saying patients, just go with it, guys. So what they showed was that even when we're controlling for all of these other variables, serious psychological distress still has a really strong association with having Alzheimer's disease-related dementia. And it's actually the second strongest association after age, which we know age is obviously the highest risk factor that anyone has for Alzheimer's disease. So seeing that SPD score being that strong is pretty significant to me. Another thing that I want to point out, so in model 1A, another variable that had a strong association with having Alzheimer's disease was African American race. And if we look at model 1B and looking at other health conditions that the participants reported, the presence of depression and anxiety were both associated with having Alzheimer's disease-related dementia. And again, I just want to point out that the presence of anxiety and depression was a much less reliable diagnostic tool that we could use in minority populations because they were much less likely to have those diagnoses compared to having a higher SPD score. So the final analysis that they did was they wanted to try to figure out like how heavy that SPD burden was on the disease process itself. In my opinion, that's a pretty difficult thing to do. And at this point in their analysis, things, just from my perspective, got a bit hairy. But basically what they were trying to calculate was the predicted probability of ADRD in the African American, Hispanic, and non-Hispanic white populations. So, we see that there are higher rates in both minority populations compared to the white population. And the researchers then came up with this model based on all the variables that they collected from these participants. And they said, okay, well, they calculated that 19% of the difference between, the probability of having Alzheimer's disease between African Americans and whites was due to their model. And among that model, serious psychological distress specifically accounted for about 15% of that. If we then look over to the right, doing that same analysis, the researchers said that the total difference percentage explained by their model was about 90%, and 40% of that was from serious psychological distress. So their overall conclusion is that serious psychological distress, might be an increased risk factor for having Alzheimer's disease-related dementia, or might contribute to a heavier disease burden in minority populations. And so a few things that I wanted us to discuss is just the timing of using the SPD score. If we use it pre-diagnostically, it could be a possible risk factor or a possible diagnosis if things are occurring early on in the disease process. Again, this takes us to the very beginning of our talk where, that temporal relationship still needs to be better understood. And if we start using these behavioral markers more in neurological care, then we might be able to figure that timing out. So Post-diagnosis, I think the SPD scores are really important because if the patient has a high score, but let's say they don't have a diagnosis of depression or anxiety, their mental health might not be managed properly while they're going through a really difficult disease process. So going further along with the discussion, a few things that we can talk about. The reason that there is underdiagnosis of depression and anxiety in minority populations is this due to access to resources? Is it due to the clinical encounters themselves? I also would like to talk about what you guys think about the serious psychological distress scores, because I think their use can be broadened. So, I'm wondering when and where they should be implemented. Should it be a family practice type of thing? Should, we do it in neurology? It should be a psych, all of the above. Also, I talked about a little bit earlier the quantification of the SPD scores and the possibility of a threshold. Not sure if you all are familiar with like adverse childhood experiences or ACE scores, but that's a behavioral marker, and children with, they say, 4+ adverse childhood experiences have this just drastically increased risk of many medical issues down the road. And so I'm wondering if something similar can be looked at here, and we're saying, okay, well, patients in this group with this score particularly have like a really high risk of possibly developing Alzheimer's in the near future. We can also look at whether serious psychological distress is, associated with specific types of Alzheimer's disease compared to others, if it's associated with possibly an earlier onset or a worse progression of disease if it's present. And, taking these SPD scores once a patient has a diagnosis could also be helpful, because let's say they stay static, well, maybe it's more of a risk factor in that case, but if the SPD scores were to increase with progression of the disease, that might point towards it being, possibly related to the pathology of Alzheimer's. So, in conclusion, I hope you all have enjoyed going on this, little behavioral venture with me. The presence of SPD is associated with significantly higher likelihood of having ADRD, and SPDs among African Americans and Hispanics contribute to greater disease burden compared to whites. So this is everything we learned from the study. As for next steps, I am, advocating for more reliance on subjective screening and integration into personalized healthcare and neurology, and specifically the use of SPD scores in minority populations, which may have lower rates of mental health diagnoses. And also another thing, for us to consider is just better mental health diagnosis in minority populations. In this context, we are talking about Alzheimer's disease and neurology, but, even if the SPD score is particularly useful in these populations, it's still a big deal that there might be this discrepancy between having that high SPD score and not having a mental health diagnosis and not having that attended to. So these are my references, and these are some baby animals to combat any pandemic fatigue we might be experiencing at this moment. And yeah, that was my presentation. I think maybe I talked a little fast and finished early, but thank you all.
You're right on time. Thank you, Lauren.
Okay, good.
Thank you. Before I ask some of the questions that I have, I would like to open it up to the floor. I'm sure there's more questions because I feel like that was an amazing presentation. So any questions, you can just unmute and go right ahead.
Real quick, I actually forgot to thank you, Galadu, because you were really nice when you reached out to me, very supportive, and helped me also like narrow down this topic. So I appreciate that. I got distracted by the baby animals. Forgot to thank you. I meant to.
This is a great presentation. Thank you so much, Lauren. I kind of wanted to comment or respond to one of your, questions that you had asked, and that, what might be the reason for the discrepancy between the psychological distress and then also the mental health diagnoses in minority communities. And I think it could be access to resources, but it could also be stigma. Like, for instance, I know for a fact in the Hispanic community, and I'm also pretty sure in the African American community, there's a large stigma on mental health. And so I think that maybe even when they are in the office, there's not, quite that level of acceptance yet to say, mental health is okay. We can once we're able to identify it, we can then work on improving that experience. I will say though, for a fact, because I did look into this a little bit, there was one study that looked at a student-run free clinic, which largely serves underserved minority populations, and how their use of I think it was the PHQ-2, or maybe it was PHQ-9, implementing that in their practice, which is a primary care setting, they did identify depression, undiagnosed depression, quite significantly, and then they were able to, provide intervention, whether it be pharmacological or behavioral interventions. And so I think that it could, to answer your question about where we feel like the utility is of having this questionnaire, I think it can be really widespread. I think it could be in the psychiatry office, in the neurologist office, in primary care and geriatric. So yeah.
You faded out the end of the question there, but I actually did want to follow up right on that. Just a quick little thing. I think I might have missed this. Was the depression or anxiety diagnosis by clinician, or was that self-reported?
It was self-reported, but then it was confirmed with their doctors afterwards.
Okay, so if they didn't report it, it wasn't necessarily unconfirmed. Is that
correct? Yeah, no, that's a good point. So if they happen to have the diagnosis but didn't want to report it to the study, then that could.
Yeah, and that kind of going back to that stigma thing that Roxy was saying. It's just all these things kind of factor in, and how do we get the data that we get?
Yeah.
Anybody else with a question?
I think that's an interesting point though, because you look at the SBD score in those questions and it's essentially asking the same thing, and yet it's not this like label or this big thing. So it's sort of easier to say, well, this is how I'm feeling and it's not so great, versus these are
the specifics of what I have. Yeah. Because if you say this is depression or this is anxiety, maybe your opinion of that is altered. The other question that I did want to ask was about, I don't know if I found any reasoning, or if you found that, of why they think the Hispanic population model was so predictive, because it was like 90%, right? The model. So that's like, essentially that model should be, we should start using that in that population. But it's like, did they give a reasoning why? And then follow up with that being, why was it the most predictive when that was actually the least difference between like the starting point and the finish point, right? Like that was 25 to 45, whereas like the whites was 15 to 45, so it's like, I'm trying to understand how those two things mesh.
I agree. And I kind of looked at that too, and they didn't explain why. And I also looked at, I was like, well, why is this, why is their model explaining 90%, Hispanic white versus, it was only like 20%. And so, they didn't really explain it that well. But yeah, that's unfortunately the best answer for you.
It's very interesting.
They also, in their first analysis, they didn't even mark Hispanic ethnicity as like being strongly associated with Alzheimer's disease-related dementia. It was just African American race. So, I'm not sure if that has anything to do with, just the number of participants that they had. I was curious about what you guys thought about the distribution of, this study had 65% white participants, but I had actually looked at some other articles, looking into this topic. And one of them I found was talking about differences in patient populations based on race. And then I went to their data. Only 1% of the study participants were African American. And I was thinking, how is this a study? It's 1% of everyone in your study, and they had a really large sample size. But I mean, you know, so I thought that those numbers were pretty good compared to some other things that I had seen, but you know, they could be better.
That definitely seems, I mean, at least, you know, more representative, if not anything else, than 1%, like you're saying.
Yeah.
Crazy. Well, if there aren't any other questions, I would like to once again say thank you, Lauren. This was a great presentation. Thank you for the discussion and for the cute baby animal pictures at the end. And there will be another NeuroEquity Journal Club next month. I invite you all. Let me see if I can actually find the exact date that it will be on. It will be on May 18th or May 19th. But obviously all the information will be going out. Thank you guys for coming, and enjoy the rest of your evening.
Thank you. And good luck to anyone studying for boards. We were talking about that anxiety a little before the presentation started.
Alrighty. See you guys.